All right, we're going to talk about cardiac ultrasound, and really on this first session, going to focus on getting the windows. There's 5 major windows of the heart. We're going to go through those 5 windows, and in between some of these windows, we're going to show some pathology. So, without further ado, the parasternal long, apical 4-chamber, and subxiphoid view of the heart are seen here with their respective indicators. The indicator in the parasternal axis, when it's in the long axis, is to the patient's left. When it's in the parasternal short axis, it's actually to the patient's right. The apical 4-chamber view is seen here with the indicator to the patient's right, and the subxiphoid view is seen here with the indicator to the patient's right. To go through these a little more detail, the parasternal long axis, again, as its name suggests, parasternum, you've got the probe right next to the sternum. So if the sternum is right here, you've got the probe. I actually put the probe on the sternum and then just slide it off a little bit, aiming the indicator toward the patient's left if I'm doing the parasternal long. And this is what the transducer looks like that we use. It's the P21 or phased array, small footprint, 21 millimeters of footprint there right along the parasternal region. And what you're doing is a long axis of the heart. So we don't say sagittal or transverse when it comes to the heart, because the heart doesn't lie in the same plane as, say, the aorta. It's kind of cattywampus. It's off to the side, so we say long or short axis. And so in this case, we're going to be talking about the long axis of the heart. Indicator goes down toward the patient's left hip or left elbow, and essentially, when you get a CAT scan, this is a CAT scan image here. What we see here is the sternum, and then we can see the left ventricle is down here. The right ventricle outflow tract, as sometimes it's called, or the right ventricle, you could say, is up here, and then the left atrium is down here. So it's really a 3-chambered view. So the blood's going here from the left atrium into the left ventricle and then out the aortic outflow tract. So we can see the RV, the LV, and the LA, and this is the aorta seen distal to it here. Notice that the heart is in a long axis while the descending aorta is seen in a short axis. And it's right up against the pleural space. In fact, the pericardium is what surrounds the heart, and the pericardium and the pleura are right up against each other right here. That reflection is coming along right here. And this is what it looks like, just another schematic of this. The parasternal long axis, we can see the left atrium goes into the left ventricle through the mitral valve. This is the anterior leaflet of the mitral valve, sometimes called the septal leaflet because it comes up next to the septum during diastole. And then this is the posterior leaflet of the mitral valve, and this is the aortic outflow tract seen right here, and then the right ventricle is seen up here, or on the ultrasound, LA, LV, aortic outflow tract, RV. The apex of the heart is seen down here. And this is not an ultrasound. This is just a schematic diagram demonstrating systole and diastole. So when the heart squeezes that systole, it squeezes its contents out of the aorta, and out through the aorta, I should say. And during diastole is when it fills. And you can see that during diastole, the valves open and the heart fills with blood. And this is the septum seen here. And the right ventricle, not pictured, would be right up here, parasternal long axis. And in real life, what we see on ultrasound is this. This is the left atrium, left ventricle, aortic outflow tract, right ventricle. Here's the septum. And we notice how that anterior septal leaflet of the mitral valve, I freezed it for a second, is right here. Now watch as it goes through its range of motion. Okay, so here is systole, so the heart's going to squeeze its blood right out the aorta, and as it does so, the mitral valve is closed. Now if I move along here, you'll see the mitral valve will open during diastole. And in the healthy heart, what happens is that mitral valve, anterior septal leaflet, comes up and smacks the septum, just like that. And if I back this up right here, we can see how that leaflet comes up and smacks the septum. You see that? See how it's doing that? Who's your mitral valve? Who's your mitral valve? See how that works? Okay, good. Just want to make sure that we're all on the same page there. That's normal. The other normal thing that I see going on here is the septum and the posterior wall. Now, what you like to see in the normal heart is that, imagine you're a little red blood cell sitting right here in the left ventricle, and you look up to the septum and you look down to the posterior wall of the heart, and they both come towards you with a good degree of motion. and that's good. So another way to think about this is the end diastolic volume that's in the heart compared to the end systolic volume. So let's see here. Here's the end systolic volume. Notice that there's just not much left in terms of the volume. That's good. It pumped it all out. Compared to the end diastole, where it's nice and full. And so what you kind of want to look at is the comparison of those two volumetric measurements. Now you can do a lot of fancy calculations here, but a lot of studies have showed that a qualitative look at the heart by looking at the septal leaflet and by looking at this squeeze here is enough to judge whether the left ventricle is functioning well or not. So this is a normal parasternal long axis of the heart, and just to lay the anatomy on there a little bit for you, you can see this is like the descending aorta seen down here. Here's another example here of a parasternal long axis. Again, we see the left atrium, left ventricle, aortic outflow tract, right ventricle, and there's that descending aorta seen right here. We see this mitral valve comes up, and let's see if I can get to do it right. There. Boom. Nice and close to the septum. We like to see that. And then we see some good squeeze of that chamber as well. So again, I look at the anterior septal leaflet of the mitral valve, and I go ahead and look at the posterior wall and the interventricular septum and how well they squeeze towards one another. And clinically, the way I would use this is, let's say this patient had low blood pressure, and I'm trying to decide what to do next. And generally speaking, I can give more fluids to try to get the patient back up on that Starling curve. Or occasionally, the heart doesn't beat strong enough, so I have to be very careful with fluids. You see, because if the left heart doesn't beat strong enough, you can get buildup of fluid into the lungs and resulting in pulmonary edema. So it's easy to put a patient into what we call fluid overload if we don't have a patient with a good functioning heart. Take, for example, this heart. Is the mitral valve coming up and smacking that septum? Nope. What about back here? Do we see a lot of good squeeze here? A lot of delta or change in the chamber size between end systole and end diastole? Nope. So this here is a patient that, if the nurse comes to me and says, Dr. Fox, the guy in bed 5, his blood pressure is 70. Is it okay if I give him a liter bolus of fluid? And you're tempted to say, sure, go ahead and do that. Let me know what the blood pressure shows when you're done. But really, the right thing to do is go to the bedside, take a look at the patient's heart. Because if you saw this heart doing this, you have to be very judicious with the use of fluids. In fact, you may consider going straight to another therapy, like an inotropic therapy, like dobutamine, to try to get the heart to squeeze harder. So this patient has poor left ventricular function. So we use this every single day in the emergency department and up in the ICU.
Screening athletes for heart problems. Dr. Barry Ramo reveals how certain tests can save lives.
It seems like every week we hear about competitive athletes dying suddenly on the playing field. The question is, should competitive athletes be periodically screened for heart problems before they compete? A recent study published in the British Medical Journal found if athletes were screened before an event, the risk of sudden cardiac arrest could be detected and lives could be saved. In Italy, where all athletes are screened, scientists looked at more than 30,000 athletes who underwent an electrocardiogram and found almost 5% of them had some heart abnormality that could lead to sudden death. According to researchers, a young athlete dies every 3 days from an undiagnosed heart problem in the U.S. That's because in most cases the problem goes undetected until they compete. The major cause of sudden cardiac death in athletes is a disease called hypertrophic cardiomyopathy. Often patients with this problem will have a family history of the disease, there'll be a family history of sudden cardiac death, or they'll have some physical findings on examination. But the best test is an echocardiogram, which is an ultrasound of the heart. So far, we're not doing routine screening of athletes, whether they're professional athletes or whether they're just regular high school athletes. But that might be something in the future to weed out those kids who are at high risk for sudden cardiac death. For HealthBeat, I'm Dr. Barry Ramo, KOAT Action 7 News, live this morning.
So now that you know how the what the peristernal long axis looks like, you can get an idea of where the septum of the heart is. And you can see here with this patient who's got septal wall, or asymmetrical septal wall thickening right here. In other words, it's the septum that's thick and the other walls look okay. This is what's known as hypertrophic cardiomyopathy. And you saw that little catheter go in there, and they can treat that by injecting ethanol right into the septum to help shrink it. And because, see, what happens is as a person's exercising with this septal hypertrophy, it can actually block the outflow of the blood out the left ventricle into the aorta, and they can have syncope. They can pass out because not enough blood is getting up to the carotids to get blood to the brain. And so to identify this, you can't really diagnose it using an EKG. It doesn't have good enough test characteristics, but ultrasound has excellent test characteristics to pick this up. It's really easy to do. Now that you know how to get a peristernal long axis, this is actually a relatively straightforward and easy thing to screen for. I'm just throwing this in there as sort of a clinical correlate to make this interesting. So patients who have hypertrophic cardiomyopathy can have all kinds of non-specific types of symptoms, and none of these really point exactly to the diagnosis. It's just, could be lots and lots of different things can cause all these things. And so that's why you end up turning to imaging to help you with your diagnosis. Now, this is a patient here who does not have hypertrophic cardiomyopathy. Really, it's just this is the septum here, and you look at it and you can freeze the image here, and then you can measure across the septum using the calipers. Now, what you can do is kind of glance over here. These are 1 centimeter hash marks, and as long as this is less than 1.2 centimeters, then it's normal. As this next chart shows here, a normal septum is between 0.8 and 1.2 centimeters, and so that's kind of the thing to memorize. And then once you get above 1.5 centimeters, you get this hypertrophic cardiomyopathy. Now, sometimes you can have something called athlete's heart, which is the heart can, like any muscle, can enlarge when you're using it a lot, but it is enlarged symmetrically. And so over here with hypertrophic cardiomyopathy, it's only the septum that gets thicker compared to athlete's heart. And then family history of sudden death is often very common in hypertrophic cardiomyopathy. And this athlete's heart goes away if you don't exercise for 3 months, whereas this septum stays thicker. So just a little clinical correlate to show you. And this is an interesting ultrasound of what can happen. This is called SAM, or systolic anterior motion of the anterior or septal leaflet of the mitral valve. So remember, this is the left atrium, this is the left ventricle, this is the aortic outflow tract. And look what happens. This is a very thickened septum. So this is, these are little 1 centimeter hash marks here. So this is approaching 2 centimeters. And what happens is during systole, you can see how that anterior septal leaflet moves anteriorly, moves up towards the chest wall anteriorly. And that motion right there occludes the aortic outflow tract, and this is exactly what can cause syncope and even death if you don't get enough blood to the brain. Just to point out the anatomy, we can see the descending aorta in its cross-section seen right here, just posterior to the heart. This is just another case of hypertrophic cardiomyopathy. You can see it in a couple different windows here. This is the peristernal long, so here's the septum very enlarged here. This is the a couple views down here called the apical 4 chamber that I haven't taught you yet, but I'm about to. But you can see 4 chambers here. This is the left ventricle, this is the right ventricle, and look how thick this septum is, and it comes all the way out here like so. And so this is just another example of hypertrophic cardiomyopathy. Again, the peristernal long axis is a nice way to view it. Now, to move into the peristernal short axis, what you do is you go from that 90 degrees from the long, you get into the short. And so all you need to do is rotate the transducer from like the left hip over to the right hip. And then you'll see the short axis. And if you're very superior on that short axis, or another way to think of it is very proximal, see, because here's the short axis of the heart over here, you can be very proximal and you'll see the aortic valve, which is what this looks like right here. Here's the aortic valve here. Because it's a tricuspid valve, when you get it in this axis, it looks like a little Mercedes-Benz sign. Now, if you were to take the sound and walk it down more distally, okay, or you can angle it inferiorly is another way to think about it. Now you're going to be over a different valve. This is the mitral valve here, and that mitral valve is what we sometimes refer to as the fish mouth view. You see the little fish mouth opening right there. And then eventually you go down even more inferiorly and you'll get to where the papillary muscles are right here. In fact, that's a good example here of the mid-pap view. Call that mid-pap. It's down towards the apex. So you've got the probe in the same plane, but you can just be at different cross sections. You can be, whoops, go back to that. The probe is really the same plane, but here we are, again, very distally at the mid-pap view, the papillary muscles we see there. We get a little more proximally, and we can see that fish mouth view of the mitral valve. And then even more proximally in the peristernal short axis, we can see the aortic valve. Now this whole structure here is all left ventricle. There's a little tiny piece of the right ventricle seen over here. Again, all left ventricle. Little sliver of right ventricle is seen up here. Much more right ventricle is seen over here on this more proximal view. And eventually you get to see the left ventricular, I should say, the right ventricular outflow tract as it comes down to the pulmonary artery this way. So if you wanted to see the pulmonary artery, you can do so transthoracically using ultrasound in the peristernal short axis, very proximally where you see the aortic valve. Sometimes you get lucky and see a pulmonic valve right along here. Another example of the peristernal short axis, we see the right ventricle here, the left ventricle over here. This would be a mid-pap view down towards, or mid-papillary muscle view down towards the apex. More proximally there we see the aortic valve, and maybe even a little bit of pulmonic valve if I hallucinate a little bit over here. Now, this is just a little clinical correlate here for you. This is down the peristernal short axis, down towards the papillary muscles, down towards the apex. And what we see around this is a large pericardial effusion. So the pericardium is actually out here. And we see the heart just kind of bouncing up and down in this pericardial effusion here. Now the apical four-chambered view, what you're going to do is you're going to go to where the PMI is. The PMI is the point of maximal impulse. It's a dime-sized space or location where the heart comes to the chest wall. You can even feel it on yourself, just kind of on your left chest if you lay towards your left-hand side. So if you're laying in bed and you roll off to your left and you put your hand on the left side of your chest, you'll feel that PMI come right to your hand. And there's a little point where it does that, and that's where you want to place this transducer. Now patients who have chronic obstructive pulmonary disease or who smoke a lot, they lose that PMI, it goes away because their lungs expand to fill that little space. And so smokers, this is a very difficult window to obtain in patients who smoke or have chronic obstructive pulmonary disease or COPD. But this next week with your models, you'll see none of them do that, so they all have really good PMIs, and so this is a pretty easy window to get, hopefully next week. Now, as this guy's laying over, I don't know if you could tell or not, but he's kind of laying off to his side. He's on his left side. So that's the position the patient really needs to be in for this apical four-chamber view. It also helps to do that for the peristernal long view as well, to tell you the truth, because that brings the heart to the chest wall a little bit better. So either of these views, it helps to have them lay on their left side. This is a nice view to compare the chamber sizes, because here we see the left ventricle, the right ventricle, the left atrium, and the right atrium. And on the left side of the heart, we can see the mitral valve. And on the right side of the heart, we see tricuspid valve. But notice how the right ventricle is about 2/3 the size of the left ventricle. And that's normal. And as the right ventricle gets bigger and bigger and bigger, there could be some problems there with the right ventricle trying to pump blood against an obstruction like a pulmonary embolism. And so in the setting of massive pulmonary embolism, or blood clot in the lung, the right ventricle gets so big it approximates the size of the left ventricle. So that's how I use this view clinically. So it looks kind of like this, the schematic. Here's the left atrium, left ventricle, right atrium. Apical four-chamber view. Another way to think about it is you put the probe over here underneath that left nipple, and you're shining left ventricle, the left atrium. The right ventricle is over here, the right atrium, if the image was upside down. So if that confuses you, don't worry about it, because that is confusing to me too. But this is what it looks like. You've got the probe here at the top of the screen, and the sound is coming out, and we've got the indicator to the patient's right. And so the right ventricle is over here, left ventricle is here, left atrium, right atrium. Nice how this right ventricle is about 2/3 the size of the left ventricle. That's good. Just the chambers with their labels there in case you forgot. There's your mitral valve, and there's where the tricuspid valve is.
Fourth view, you want to have the indicator here towards the patient's right again. You're sort of right underneath that left nipple, aiming towards the spine. And that view there will get you the heart on the screen to stand straight up with the septum standing top to bottom. That's the septum there. This is the left ventricle, right.
Just another example of a normal apical four-chamber view, LV, RV, RA, LA. We see the septum standing straight up and down the screen, and both sets of valves there. What do you think is going on here? Well, this is the pericardium out here, okay? And we can see the heart with the LV here and the RV here. And to give you another hint, I don't know if you can tell or not, but this is something called electrical alternance, where the axis of the heart changes this way, beat to beat. The axis of the heart changes. And that happens when you've got the heart swinging around in a very large pericardial effusion. But the most common finding on an electrocardiogram of pericardial tamponade is not electrical alternance. It's just simply low voltage ECG. But it is cool when you see electrical alternance. But again, echo is a much better test than electrocardiography is for this diagnosis. Now, you may remember we talked about Doppler. I'm going to bring this up again because it's important with the valves. So remember with Doppler that you've got this scale here. What this means is the red is towards the transducer and blue is away from the transducer. And so as another way to think about this is BART, blue away, red towards. So that's, in fact, I say that to myself a lot when I'm getting confused sometimes with color flow. Okay, I'm like, okay, BART, blue away. All right, so the blood's moving away from me now. This is what an abdominal aortic aneurysm looks like here. And it's just showing that blood is moving in sort of both directions here in this sort of yin and yang pattern, turbulent flow. And it's just a sort of, it just looks kind of cool. You can see both colors there. It doesn't really mean anything diagnostically. But with the heart, we can use Doppler to evaluate the valves. Now, this is an example here of the parasternal long axis, just to demonstrate where that mitral valve is. And one of the things you got to remember about Doppler, it's a little bit confusing initially, but you gotta kind of commit this to memory, is that when you work with Doppler, you can't have the Doppler assessment at 90 degrees to the angle of the sound. In other words, this is the parasternal long axis of the heart. Here's the left atrium, mitral valve, left ventricle, aortic outflow tract, right ventricle. The mitral valve is exactly 90 degrees. It's perpendicular to where the probe is, and the flow is moving at a 90-degree angle. So this is the incorrect way to try to assess the mitral valve when using color. Instead,
a healthy mitral valve keeps your blood moving in the right direction. A leaky valve,
and I'll show you what I mean by that here. So this is the apical four-chambered view, and we see the LV is here, the RV is here, and the way the sound is aiming, it's like you think about the probe with throwing the sound down the barrel of a gun. And what I mean by that is now the flow is either coming up directly towards the probe, more parallel to the sound rather than perpendicular, and that gives you a much more accurate assessment of what's happening with that valve in terms of color flow. And so if this is the left atrium and this is the left ventricle, just to kind of make this clinically correlate for you, during systole, right there. You see how this heart squeezes during systole. We expect the blood to flow out the aortic valve, which isn't seen in this view. What we don't want to happen is this. We don't want the blood blue away. We don't want to see this blue jet come squirting all the way back to the back wall of the left atrium. So this is severe mitral valve regurgitation. See, during systole, I should say during diastole, we see we see the red come right up into that ventricle, which is what we expect. But then during systole, we see all this blue away right through that valve. And that's severe mitral regurg when you see that. So put it another way, we see another blue jet on this other heart squirting to the back wall, and that's not good. That's not supposed to happen. That valve is incompetent, and we have a lot of blue away happening right there. And unfortunately for the same patient, they also have tricuspid regurgitation. We see this blue away jet happening a lot during systole down here as well. Just another schematic of that apical fourth chamber. I like seeing this left atrium, left ventricle with the papillary muscle seen there. Now, what's interesting here is that on this particular drawing, we can see the aortic valve. And normally we just don't see it when we're looking at the apical fourth chamber view here. We don't see that aortic valve. I mean, they're kind of trying to point it out here to you, but frankly, I don't see it. It's not until you tilt the transducer more anteriorly will these two structures start to move away. The RV and the RA kind of go out of the picture, and now you get a lot more of the aortic valve in the view. And that's called the apical 5 chamber, the 5th chamber being sort of air quotes around the aortic valve. You basically just tilt the transducer or angle up from that apical 4 chamber view. You just kind of angle it up a little bit, and you'll start to see a lot more of that aortic valve come into view, the aortic outflow tract. So you see what's happening here? We're losing that RV and the RA. Now we're starting to see this aortic valve in here, the aortic outflow tract. This is the LA and the LV seen here. And if we put a little flow on here, during systole, we see the blood going blue all the way down through the aortic valve. And that's what we want. We want to pump that blood right out of there. That's the idea. Here we see the aortic valve here as well. So that's the apical 5th chamber. And the reason why this is important is because we're going to go ahead and drop pulse wave Doppler over that apical 5th chamber and measure the velocity of the flow that's going through this left ventricular outflow tract. And using some calculus, we can calculate the cardiac output of the heart beat to beat. Let me show you how this works. So in order to calculate the cardiac output, we need to first go back to that parasternal long axis. Remember this? And we're going to measure the left ventricular outflow tract diameter. So here's the LA, LV, aortic outflow tract, RV. So it's this aortic outflow tract here that we're interested in. In fact, we can blow it up. We can hit the zoom button, and that zooms in on it. So as the heart's beating, we get a nice parasternal long axis. We let it beat for a few beats, and then we hit freeze. And then we hit zoom, and now we can go forwards or go backwards. And when we see this little minus sign right here, see that? This is when the valve is closed. We want to rotate the image. We want to kind of scroll back to where the valve is open. And you measure at the bases or the cusps here of the aortic annulus. That's where you're going to measure during systole, where you had maximal excursion of the aortic valve leaflets. Okay, so that's the LVOT diameter. And then you can write it down, square it, times it by pi, divided by 4, and that will give you the left ventricular outflow tract area. And that's going to be important here in a second. Or you just plug this value into the ultrasound machine's computer, and it saves it for you, and it does the calculation for you. But this is the exact formula that it's using. Once we have the left ventricular outflow tract area, then what we're going to need to do is get the velocity time integral, or it's the amount of blood going through the left ventricular outflow tract, which is given by this velocity time integral. And so it's the envelope of the flow that's coming all the way through that aortic valve. It's that envelope right there that we need to do a little calculus on, or integral of. And so you line up the pulse wave Doppler signal right over the apical fifth chamber, and then you activate it, and then we get this tracing. And then you can manually trace this envelope of flow, or the computer actually does it for you automatically. And so once it has that LVOT diameter which you measured, it squares it times by pi divided by 4, and then it multiplies it by the velocity time integral, or that envelope. And what that gives you is stroke volume. And the whole time the machine is watching the heartbeat, and so it knows the heart rate. And so it does this whole thing automatically and calculates for you cardiac output, which is this term, stroke volume, times the heart rate. And we'll be practicing this at the bedside stations tomorrow, or this week, whenever your session is. And finally, the last view of the heart is a subxiphoid view. And what you're going to do is you're going to look underneath the chest here. You're going to take the probe and you're going to stick it down here underneath the xiphoid process. And, I go back and forth between calling this subxiphoid or subcostal. You really start off sort of subcostally underneath the rib margin and then slowly slide it up into this subxiphoid area. And you're going to use the liver to see the heart. This is this four-chambered view of the heart. Again, we're subcostally here, or subxiphoid. So you start with the indicator of the patient's right, looking underneath the costal margin at the liver, using the liver as your window. Now, if you have a patient who's got a very small liver from drinking too much alcohol, you cannot obtain a decent subxiphoid view. But the trick is to look first over here at the liver and then slide the probe slowly right up into that subxiphoid notch, aiming the beam towards the chin. You never want to go past midline, because if you go over here to the left side of the body, well, there's no more liver over here anymore, and you're not going to see the heart. You got to stop right about midline and aim the beam right towards the chin. And what you see here is liver on the top of the screen, because that's what you're using. That's your acoustic window. You're throwing the sound through the liver to first see the right ventricle in the right atrium, and then see the left ventricle in the left atrium. Okay? This is that anterior pericardium over here, and then the posterior pericardium is down here. And maybe there's a little mitral valve here and tricuspid valve here. But really, this is the best view in order to see two things. Number one, I use it when a patient's dead and they're coding, they don't have a pulse, and I want to see, are they really dead or not? I want to see, is the heart actually standing still, or is the heart moving? You'd be surprised how many times somebody doesn't feel a pulse, myself included, but when I go to look at the heart, it's actually moving. So it helps you determine that more accurately when you can actually see the heart moving. The second thing I use this for is for pericardial effusions. This is the best view, sort of the most sensitive view, to check for somebody having a pericardial effusion or fluid between the myocardium and the pericardium. This is a very sensitive window for that. You see, in a supine patient or somebody lying flat, the heart is heavy, and it sits in its posterior pericardium, squishing any fluid anteriorly. And so this is exactly where you see these pericardial effusions, right along this anterior area, like we do here. So here we see this pericardium here, coming around down here. We see the chambers of the heart in this subxiphoid view or subcostal view. Here's the liver. Here's the liver. That's our window to see the heart. And we can make out, and this heart has a pericardial effusion. Here's another example here of a pericardial effusion. We can see the liver here. Notice how I start at the liver and I just rotate the transducer into that subcostal notch, and subxiphoid notch or whatever, and I can see this pericardial effusion up in here. Looks like a little man is inside jumping up and down on a trampoline. So, to conclude, it's sort of a clockwise approach when we're looking at the heart. That's kind of how I think to do it. I start up in that parasternal area. First, I kind of look over to the patient's left hip or left elbow to get the parasternal long axis, and then I aim the indicator over to the patient's right to get the parasternal short axis, and then I slide that transducer just below the left nipple with the indicator to the patient's right, and then I move it to the subxiphoid area with the indicator to the patient's right. So I start to the left, and then I move to the right, and it stays to the right, the indicator that is.